Welcome, everybody. Thank you for joining us today for the Kirby Institute seminar series. My name is Dr. Sarah Sasson, and I'm a senior lecturer in the Immunovirology and Pathogenesis program. Of course, as we meet here today, as today's researchers and scientists, we acknowledge the First Nations scientists who've been building community, exchanging ideas and finding solutions on these lands for many thousands of years before us. So I'd like to begin by acknowledging the traditional custodians of the lands on which we gather today and pay my respects to their elders past and present. Today we're presenting from Bedegal people, the Bedegal lands of the Eora Nation, and I extend that respect to Aboriginal and Torres Strait Islander people joining us today in the audience and also online. Some housekeeping to start off with. So the format for today's seminar there'll be 4 presenters: Professor Gail Matthews online, Dr. Rahana Hua-Vicente, who will be in person, Ms. Joanne Carson, also online, and Dr. Win-Min Han in person. So there'll be no questions at the end of the individual talks, but there will be a panel Q&A session after. If you're joining online, you can ask questions by clicking on the Q&A icon at the bottom of the screen. And for our live audience today, a show of hands during the Q&A session to assist us to direct your questions. Okay, so we begin today with our first presentation from Professor Gail Matthews, who is an infectious diseases physician and program head of the Therapeutic Research and Vaccine Program at the Kirby Institute. She's also head of the Infectious Diseases Department at St Vincent's Hospital, Sydney, and has held UNSW CNTF Fellowship and NHMRC Career Development Funding. Welcome, Gail.
Thanks, Sarah, and welcome everybody. Apologies for not being there in person. I'm on site at the hospital today. I'm just going to try and share my screen, and also thanks for the opportunity to present this really important data that was presented at CROI this year as a late breaker session in the antiviral session on the last day of the conference. So it's great to be able to share it with you all today. So it's great to be able to present this data from the D²EFT study, D²EFT standing for dolutegravir and darunavir evaluation in adults failing first-line non-nucleoside reverse transcriptase inhibitor therapy. And I'm presenting this obviously on behalf of the entire D²EFT study team. So it's important to understand a little bit of the history of the D²EFT study. D²EFT was originally conceived as just a 2-arm randomized clinical trial, which was comparing one innovative simplified dual ART regimen, that is the intervention arm shown there as arm 2 of ritonavir boosted darunavir, a protease inhibitor based therapy with dolutegravir. So this was innovative because it had no nucleosides, it required no genotyping, and there was a potential for co-formulation. And that was to be compared with what is standard of care in WHO practice and guidelines, which is ritonavir boosted darunavir with 2 nucleosides, with those nucleosides selected on the basis either of genotyping, if that was available at the sites, or on the basis of the WHO algorithm, which says which drugs to use as nucleosides in second line. So that study, that 2-arm study, commenced in 2017 in April. However, it quickly became obvious in the first year of the study that there was really a change in therapeutic landscape. The results of the Dawning study were released, and also there was the widespread global rollout beginning of the triple drug fixed combination TLD, tenofovir, lamivudine, dolutegravir combination, which was really becoming very widespread. So there was a significant amount of stakeholder consultation, also requiring additional funding to adapt the study to make it more responsive and to answer a more topical question. And so in May 2018, a third arm, so a second intervention arm, was added, and that was dolutegravir, with a backbone of either FTC or 3TC, shown here as XTC, with tenofovir So that is recycled nucleosides, because most people would have been on XTC, TDF as first-line therapy, but going to that as a second line with no genotyping. This is often obviously a co-formulated pill in the context of TLD. Now that addition of a third arm required an extensive redesign of the study, because it's complicated to add a third arm after you've initiated a study. The study is or was designed to show a non-inferiority against standard of care in terms of the HIV RNA suppression, less than 50 at 48 weeks. That's the primary outcome, using a delta of 12%. So the study was really conducted in two stages. In stage one, just those two original arms were enrolled. And then in stage two, which was the majority of participants in the study, there were three arms, and obviously that required a slightly lopsided randomization process for the third arm to catch up in terms of the total number of participants being spread equally across arms. So the sample size was increased from just over 600 for the two-arm study to just over 1,000 for the three-arm study. It's important to realize that when we talk about the results, we can compare arm 1 and arm 2 across the entire both stages, but when we are comparing anything involving arm 3, we can only compare against stage 2 contemporaneous enrollment of arm 1 and arm 2. So in that second box there, because obviously there were differences in enrollment of the participants depending on the time period. The key study eligibility, it was adults, and they had to have failed first-line non-nucleoside therapy with a backbone of 2 NRTIs based on at least 2 consecutive RNAs of greater than 500, at least a week apart after a minimum of 24 weeks exposure. Key exclusion criteria: obvious prior PI or integrase inhibitor exposure, being having chronic hepatitis B infection, other significant comorbidity, pregnancy, breastfeeding, etc. Now, data presented here are in modified intent to treat analysis. So this includes all patients except those who were randomized but did not subsequently commence their ART for various reasons. There were only a small number of those. So just in terms of recruitment, and again, this was slightly complicated because of the timelines of the study and what happened over that period. In total, 831 participants were recruited over 14 countries, and this is low and middle income countries. You can see the spread of countries in the map there at the top right. And a couple of important things to note: the majority of those patients were recruited in stage 2, and there were addition of several countries in stage 2 to allow for that expanded recruitment. The total study was stopped at 831 rather than the 1,000, and that was not based on any understanding of the results or early analysis of the results. It was purely a decision made on logistics and feasibility, as well as wanting to have a timely readout from the study. And that's because the study had taken some period of time to enroll. There were 2 pauses to the study. The first, as I said, to add that third arm in between May and October 2018, but then another significantly longer pause between March 2020 and November 2020, which was related to COVID-19. And that really set recruitment back during that period. And obviously during this time, the global rollout of TLD continued. So the study team, after much consultation, decided to finish recruitment in December 21, with the last patient randomized in January 22, allowing for the 48-week primary outcome to be presented earlier this year. It's important to note that despite these really major challenges to recruitment of the study, the engagement and the ongoing care of these participants, particularly through COVID, in relation to the study was exceptional across these sites. We only had 7 withdrawals and 3 lost to follow-up across the entire study period of over 800 participants, and I think that's really remarkable. In terms of the baseline characteristics, I won't go through this in detail, we don't have time, but you can see here, just in the total column, that the majority of patients were just under the age of 40. Slightly in the majority were women. It was predominantly Black African ethnicity, although that did change slightly over and become more common over the course of the study. Median CD4 count just over 200 and an HIV viral load of 4.2 logs. Now, in terms of the NNRTI used at first-line failure, the majority of patients were failing with an efavirenz-based regimen, as we might expect from WHO countries following WHO guidelines. In terms of the nucleoside agents used in second line with the standard of care arm, again, as we might expect, based on the algorithms, 76%, so around just over 3/4, went onto an AZT-based backbone, and that has some implications for toxicity and tolerability. So here is the primary outcome results, and you can see here on the graph on the left, if you just look at the second half, so the 3 bars there of stage 2, because this is the comparison that includes the third arm, you can see viral suppression was anywhere between just over 70 to almost 85% at week 48. The important analysis shown here on the right, which is the non-inferiority analysis. In the top half there, we have the dual darunavir dolutegravir arm compared to standard of care. And in the bottom half, we have the second intervention arm, the dolutegravir TDF XTC arm, again compared to standard of care. So both of these arms are being compared to standard of care rather than to each other. And you can see there are 3 viral load thresholds, 50, 200, and 400, with 50 was the primary outcome. Both arms, novel arms compared to standard of care, met the non-inferiority threshold. You can see the margins here of 10 and 12% in reds. They were clearly way within that. Also, the top comparison, the standard of care versus the dual arm, also met the criteria for superiority, with that confidence interval there not crossing 0. In terms of the other important parameters we looked at, the mean CD4 count change is shown here by study arm, again in stage 2 only. All of the 3 arms showed a good, on average, CD4 gain of around 100 to 200 cells, because these people were obviously going on to effective therapy. But the CD4 count gain at week 48 was greater, significantly greater, by about 50 odd cells in both the dual arm and in the new sort of recycled dolutegravir TDF XTC arm compared to the previous standard of care. It was also the case when we looked at weight, another important outcome in these studies. We looked at weight gain over week 48 in stage 2 only. This is the mean weight gain on the y-axis at week 48 from base. Okay, I'm just going to start from here. Tell me if I dropped out. The mean weight gain occurred in all 3 arms, but was significantly greater in the dolutegravir boosted darunavir arm, that's the dual arm, at 2.7 kilos, and in the dolutegravir TDF XTC arm at 1.7 kilos, above that gained in the standard of care arm.
Sorry, Gail, we just lost your slides. Can you reshare?
So yeah, so this slide was really just showing the mean weight gain over week 48 in stage 2 by study arm, showing significantly greater weight gain in both the 2 new arms compared to the standard of care arm. So 2.7 kilos on average in the dual arm and 1.7 kilos on average on the dolutegravir TDF XTC arm. In terms of safety, there was no real unexpected safety signal. There were 14 deaths, none of which were treatment related. There were 97 SAEs, of which a few were possibly treatment related, and some of those are shown below. And there were 35 pregnancies. And this is important, obviously, because of the concern about dolutegravir in pregnancy. No congenital defects, with 25 of pregnancies occurring on dolutegravir. And we now know that dolutegravir is safe for use in pregnancy. Or at least there's no signal that it's not. Treatment switches due to toxicity were shown here by study arm, and you can see that they were fairly evenly split across study arms, maybe a few less in the dual arm in the middle there, with more anemia in the standard of care arm, probably because of the inclusion of AZT in that arm, and more renal toxicity in the dolutegravir TDF-XTC arm because of the inclusion of tenofovir, which obviously is the major toxicity in that setting. But not a large number of treatment switches. Now we have to do some further analysis on other parameters of toxicity within this data set. So inclusion, both the intervention arms performed well and demonstrated clear non-inferiority against the current standard of care for second-line ART in people with first-line NNRTI treatment failure. The innovative dual arm of ritonavir-boosted darunavir and dolutegravir also reached the criteria for superiority, but we have to be a little bit careful about the interpretation of this and what it means. We did not compare this to the dolutegravir TDF-XTC arm. And from a programmatic perspective, the availability of TLD as a low-cost fixed drug combination is incredibly relevant for global policy and guidelines. Both intervention arms demonstrated greater CD4 counts compared to the standard of care arm. However, weight gain was also significantly greater, and we're doing some further analyses to understand exactly the implications of this and what type of weight gain this was, whether it's good weight gain with people returning to health or bad weight gain with people becoming obese. All arms were generally well tolerated, and there were just a few treatment changes for toxicity. And participants are being followed to week 96. And as I said, there are a number of other really interesting analyses being prepared at the moment on body composition, PK, resistance, health-related quality of life, etc. So finally, obviously, I need to finish by acknowledging all of the people involved in DEFT, and there was a very large study with a huge number of people involved, all of which were critical to its success. From Kirby, in particular, I want to acknowledge Simon, who has really steered this study from the commencement, but many other people involved, and of course the study participants and community board members, very important to acknowledge. And I also want to acknowledge that there were a few major people who contributed to DEFT, who started the DEFT journey, but were not able to finish, including our very own David Cooper, and acknowledging their input as well. Thank you.
Thanks, Gail, for sharing that wonderful presentation. So we'll hold questions and comments to the end, but I'd like to invite our next speaker, Dr. Rahana Hua-Vicente, who's an early career researcher with a passion for understanding the role of T cells in virally induced cancer. Rahana works in the Immunovirology and Pathogenesis program, and her work revolves around translational immunology, T-cell biology, and HPV virally driven cancers, especially in immunocompromised individuals. Thank you.
Thanks, Sarah, for the introduction. I'll just share my screen. Good afternoon, everyone. Thanks for the opportunity to present today. And thanks, Sarah, for the introduction. So today I'm going to discuss some findings where we're actually looking at the tissue-resident memory T cell responses in the context of HPV and HIV co-infection. So briefly on human papillomavirus, so HPV, this is a virus that can be separated into high and low risk strains. Now, the higher risk strain, which is associated mostly with HPV 16 and 18, are those that are related to the malignant transformations. And this is evident in the anogenital region, cervix, and oropharynx. So once this virus infects the basal cells, if there is a persistent infection and immune evasion, E6 and O7 oncogenesis can result in this cellular transformation and carcinogenesis. This is highly dependent on viral and host factors, but we find that the immunosuppressed and immunocompromised individuals are the most at risk. So our lab is particularly interested in looking at tissue-resident memory T cells. So these T cells do not recirculate back into the blood or the lymph, but instead reside in the tissue permanently. So they downregulate particular tissue egress molecules and phenotypically express CD69 and CD103. So in a viral immunity context, they strategically localized in the tissue where they can commonly re-encounter pathogens and then host the immune response. So in my time at Centenary Institute, we looked at oropharyngeal squamous cell carcinoma that can be can be initiated by HPV. What's interesting about this cancer is that it can also be caused independently of HPV. So it's a very interesting model to understand different underlying immune T cell responses when you've got one that's caused by a virus and one that isn't. So what we found was that in individuals with a high number of these CD8, CD103 tissue resident memory T cells, or TRMs, they were highly infiltrating in the tumors compared to those coming in from the circulation with a higher percentage. And this solid red line here represents their survival. So they had much better survival if they had a high number of these T cells. What was interesting was that in the HPV negative tumors, we also saw that if they had a high number of these T cells, they also had similar survival, indicating that they might have strong anti-tumor responses. So at the Kirby Institute, we're investigating tissue-resident memory T cells in regards to anal dysplasia. So briefly, men who have sex with men living with HIV have up to 150 times increased risks of developing this anal cancer, with up to 90% attributed to this high-risk HPV-16 strain. So briefly, these individuals are on antiretroviral therapy. They have relatively normal CD4 T cell counts in their peripheral blood, yet some of them still have persistent infection, which then develop into these high-grade intraepithelial lesions, which I'll refer to as Etchells. So they can spontaneously regress, but in some individuals they don't, and then this can result in anal cancer development. So our tissue-resident memory sub-study leverages from the historic study of prevention of anal cancer, So this study recruited HIV positive and negative MSM with HPV-associated SIL. And this left a biobank of biopsies with associated extensive clinical data. So for this current study, these are formalin-fixed paraffin-embedded tissues, and we first separate them based on their HIV status, and then stratified them based on their HPV-16 status to have gain a better understanding of the CD8 and CD4 tissue-resident memory responses in anal dysplasia. We wanted to understand if HIV and HPV co-infection affect these immune responses, and whether this is implicated in those individuals that have persistent disease. So this is an image based on fluorescent microscopy, where we wanted to understand the size distribution and localization of particular T cell subsets. So each fluorescent marker here represents the cellular marker of interest, where our CD8 tissue-resident memory T cells, or TRMs, express CD8 in red and CD103 to make yellow. So essentially, pancytokeratin is a pre-tumor marker, and it highlights the precancerous lesion here. And this area is the immune belt or perilesion area. So what we found that in this inflamed kind of area here, we can see that there are infiltration of these yellow cells, and that they were quite abundant in some of these individuals. So we ended up quantifying these T cell subsets. And what was interesting was although we found a significantly but slightly lower number of TRMs in our HIV positive cohort, the CD8 TRMs were evenly distributed once we further stratified them into HPV-16 status. But what was more interesting and opposite to our hypothesis was that both CD4 TRMs and those coming in infiltrating from the periphery were significantly lower in our double positive population. Now, these individuals were on ART, and they did have relatively normal peripheral CD4 T cell counts, which have been reported. So then we decided to plot these CD4 peripheral blood CD4 counts against our CD4 tissue counts, as well as looking at it against CD8 TRM. And unfortunately, the peripheral markers did not correlate with our tissue counts. So Associate Professor Deborah Cromer performed a linear regression analysis on our tissue counts. And so A represents the tissue resident memory T cell population, plotting CD8 TRMs against CD4, and then B represents classical T cells with the same X and Y axes. So just briefly, these green lines here represents our HIV positive cohort and our blue HIV negative cohort. And we find that the steeper green lines here indicate that MSM living with HIV have relatively more CD8 T cells for the same number of CD4 T cells. So essentially, we're getting this really low CD4 T cell count in our double positive population. And perhaps although CD8 TRMs are infiltrating in that precancerous region, maybe they're not getting the essential signals for proper proliferation and cytotoxic activity. So we next performed nanostring digital spatial profiler analysis, looking at the lesion versus perilesion regions. So here we wanted to understand the different signaling partners or molecular characteristics between individuals that regress, so they have spontaneous regressions of those lesions, or those that have persistent infection and are at high risk of cancer. So essentially from these FFP slides, we selected our HIV positive HPV-16 cohort, and then we compared our regressors versus non-regression. But what's really, really important is that these biopsies were actually extracted prior to knowing what the clinical outcome was. So essentially, we performed spatial transcriptomics on this pan-CK positive area, which is the precancerous region, versus that perilegion, which is the pan-CK negative region. So this is the pre-tumor region, so this area here. And so what was interesting was that in our non-regressive lesions, so those that had persistent disease, they actually were flooded with a lot of adaptive T cell responses, MHC class 1 and 2 antigen presenting and inflammatory cytokines, compared to the regressive lesions where HPV cleared, and it was more related around homeostasis signals and metal ion regulatory pathways. Now, this is quite opposite to a hypothesis, because we thought that a lesion that had persistent HPV infection perhaps didn't have adequate T cell responses, but this is quite the opposite. We can also see a similar finding when we look at this perilesion. However, the regression lesions are dominated by this negative regulation of T cell and B cell responses, whereas again, non-regression has a lot of T cell activity and viral life cycle responses. So in summary, what was most interesting about this was that our both CD4 T cell subsets were actually significantly lower in that double positive cohort. We found that those lesions that did actually regress were surrounded by homeostasis signals versus those that are in persistent disease state, flooded with really positive T cell regulation. So this again, perhaps is due to the lack of CD4 T cell help, which is then preventing CD8 T cell cytotoxic activity. So future direction is we want to perform a single cell RNA-seq to further validate these results. And that should be really interesting because we can identify particular T cell subset that might be important for regressive cells. I'd like to thank my team leader, Dr. Sarah Sasson, Professor Anthony Kelleher, the rest of the team involved in this project, and particularly a special thank you to those individuals who donated their tissues for this study. Thank you.
Thanks, Rahana. Lovely presentation and beautiful pictures. So we'll hold questions to the end again. I'd like to invite our next speaker, who's Joanne Carson. Joanne is currently undertaking a PhD in medicine through the Kirby Institute and Center for Big Data Research in Health. And Joanne is interested in applying novel statistical methods, including machine learning, to analyze health data with a specific focus on infectious diseases. Thanks, Joanne.
Thank you, Sarah. So today I'm going to be talking about risk behaviour trajectories among people treated for recent HCV infection. Before I begin, I'm calling in from South Australia today, so I would like to acknowledge the Kaurna people as the custodians of the land here and extend my respect to them and to any Aboriginal people who are attending today. I'm presenting on behalf of the team. So this isn't something that's part of my PhD. It's something I've been very fortunate to get to work on with Marianne Martinello and Gail and the rest of the REACT team. I have no disclosures. Just to give a bit of background, hepatitis C virus or HCV is a bloodborne infection. Chronic infection with this virus causes progressive damage to the liver, and it is a leading cause of liver cancer worldwide. HIV co-infection is associated with more rapid disease progression. Adults with recent HCV infections, so a duration of infection of less than 12 months, usually have transmission risk behaviours, including injecting drug use risk behaviours or sexual risk behaviours among gay and bisexual men. One of the core tenets of efforts to eliminate HCV as a major public health threat by 2030 is to treat those with the highest risk of HCV transmission to reduce the spread of the virus. And this is known as a treatment as prevention type approach. We're extremely fortunate that for HCV, we have curative direct acting antiviral treatments. So these achieve cure in about 95% of people that are treated. However, they don't confer any immunity, and if risk behaviours continue, there may be a high risk of reinfection. The data I've analysed here comes from the REACT international clinical trial that was evaluating the efficacy of short duration DAAs among people with recent HCV infection. So this study had 24 sites globally in Australia, New Zealand, Europe, the UK and North America. The participants in this study were followed every 3 months for up to 2 years post-treatment. During these visits, HCV reinfection and STI diagnosis data were collected, and the participants also completed very detailed questionnaires on sexual and drug use risk behaviours. So the aims of this analysis were to assess population average changes in risk behaviour following treatment of recent HCV infection, use behavioural modelling to identify distinct trajectories of behaviour within the population, and finally to assess HCV reinfection and STI incidence for the different trajectory groups. Taking a look at our study population, so the population was predominantly gay and bisexual men, aside from having similar median age with the women and heterosexual men who were mostly people who inject drugs. They differed in almost every other characteristic. The gay and bisexual men had higher levels of tertiary education and current employment and much lower histories of incarceration. There was a much higher prevalence of HIV in the gay and bisexual men. Looking at drug use, the majority of women and heterosexual men had recently injected drugs, and the most common drug used was opioids, whereas among gay and bisexual men, about half of the population had recently injected, and the most common drug by far were stimulants. Looking at accessing drug treatment services, we can see some quite large differences between the gay and bisexual men and women heterosexual men, with only 15% of gay and bisexual men ever accessing any form of drug health service. So for our first aim to assess population average changes in risk behaviours, first, we plotted these behaviours over time and then used generalised estimating equations to estimate the population average effect of time since enrolment on drug use and sexual behaviour outcomes. So I'm not going to go through the model specifications, but they are there for anyone that is interested. So looking at drug use, if we look at, we've got in the black line, any illicit drug use, in the blue line, non-injecting drug use, and in the pink line, non-injecting drug use. So at screening, which is around the time when HCV was diagnosed, through to baseline when treatment started, to ETR, which is the end of treatment, to SVR12, which is a sustained virological response testing 12 weeks post-treatment. We're not really seeing any changes, and we don't see any changes during follow-up either. When we look at the type of drug used, we're not seeing any changes in any forms of drug use or stimulant use, which is in the pink. However, when we look at opioid use and opioid agonist treatment, we are seeing some changes, and these are occurring mostly around screening, so after HCV diagnosis. So in the GEE, on average, there was a 16% reduction in opioid use over time, and this is almost certainly linked to a 19% increase in the likelihood of opioid agonist therapy over time. Now looking at sexual behaviours among gay and bisexual men. So in the black line, we've got condomless anal intercourse with casual male partners, or CAI-CMP. And in the purple line, we've got group sex, which is sex involving more than 2 individuals. And we can see graphically there are some very steep declines in the prevalence of this behaviour after screening. However, it does start to come up around the end of treatment SVR12. Looking at this in the GEE, overall, we saw about a 5% reduction in the likelihood of condomless anal intercourse with casual male partners and about a 16% reduction in the likelihood of group sex. Finally, looking at chemsex, which is in the aqua line. So this refers to the sexualized use of drugs to prolong or enhance sexual experiences. So in particular, we're talking about methamphetamine, methadone, and also other drugs like ketamine, GHB, or GBL. So we can see this line looks fairly flat and there were no significant changes in the GEE. So because looking at population averaged effects can mask distinct trajectories of behaviour within the population, we use group-based trajectory modelling to identify relatively homogeneous clusters of behaviour over time. So first, looking at injecting drug use, we identified 3 trajectories of behaviour: a high probability trajectory, a moderate and a low, and we didn't see any changes in these over time. With stimulant use, we identified 2 trajectories with around half of the population assigned to the high trajectory and no significant changes in this trajectory over time. With opioid use, we do see something different. The majority of the population were assigned to the low probability trajectory. Then there was a small proportion of people assigned to this fluctuating trajectory, which eventually seems to have a trend of decline. However, you can see the confidence intervals here are very wide, and this trajectory is actually non-statistically significant. So it comes in with a p-value of 0.08. And that's simply due to the small numbers of people using opioids in this study. Now looking at sexual behaviour modelling. So if you remember that there was a population average decrease in the likelihood of condomless anal intercourse with casual male partners. But when we look at the trajectory modelling, we can see that 77% of the population remained in a high probability trajectory of this behaviour, and that didn't change over time. So a smaller proportion, 23%, were assigned to this fluctuating probability trajectory, where we see some sharp declines in the probability of this behaviour following diagnosis of HCV. Then after SVR12 testing, we're seeing those gradual increases. And what this may reflect is concern over onward transmission to other sexual partners. We see something similar with group sex. So we do have about 41% assigned to this high probability trajectory. We are seeing a little bit of fluctuation here during treatment, but generally the probability of this behaviour remained high for those assigned to this group. Then with the fluctuating probability trajectory, some steep declines in the probability of this behaviour, then some gradual increases afterwards. Finally, looking at chemsex, we had 44% of the population assigned to this high probability trajectory, and there wasn't any changes over time. I do want to note, though, that this really sits between the high and moderate probability. So it's around 0.625, the probability of this behaviour. So what this suggests is this may be a sustained behaviour, but it's not something that's occurring every week or maybe not even every month. Finally, to assess, our final aim was to assess HCV reinfection and STI incidence for the trajectory groups. So to do this, we calculated the incidence rate per 100 person years, compared them using incidence rate ratio, and plotted cumulative hazard curves just to get an idea of the temporality of events. Looking at HCV incidence, so overall in this cohort, the HCV reinfection incidence was 13.2 per 100 person years, which is a high hepatitis C reinfection incidence. And when we look at our different trajectory groups, so for those assigned to the high probability trajectory for injecting drug use, we're seeing an extremely high reinfection incidence of 33 per 100 person years, and the incidence rate ratio compared to the low probability trajectory is 4.32. Similarly, with chemsex, we see a very high reinfection incidence for those assigned to the high probability trajectory, so 23.3 per 100 person years and an incidence rate ratio of 4.08. Now looking at STI incidence among gay and bisexual men. So overall, it was around 112 per 100 person years, but this included all STIs, so syphilis, gonorrhea, chlamydia, mycoplasma, HPV, and sexually transmitted Shigella. We're seeing some very clear separation of the curves here for both group sex and chemsex. And when we have a look at the incidence, for those assigned to the higher probability trajectory for group sex, the incidence was 161 per 100 person years, with an incidence rate ratio of 1.94. And then looking at chemsex, it's 150.2 per 100 person years with an incidence rate ratio of 1.90. So in conclusion, relatively limited behavioural change was observed among those treated for recent HCV infection. High rates of HCV reinfection and sexually transmitted infections were observed. I think the study highlights, firstly, the importance of treating people with recent HCV infection, but also making sure that these people have access to post-treatment HCV reinfection surveillance and retreatment. Finally, drug health services and interventions that are specifically designed for those that used drugs in sexualized contexts are needed. I'd like to acknowledge and thank everyone that was involved in REACT. There are too many people for me to list on a single slide, but I do in particular want to thank the principal investigator, Gail Matthews, Dr. Marianne Martinello, who's given me amazing guidance through this advice and been very patient with all my questions, Sebastiano Barberi for statistical support, and Elise too for study coordination. I'd also like to thank all the study participants, the site investigators, the protocol steering committee, the data managers and site coordinators that were on this study.
Thanks, Joanne, for a great presentation on very important work. So please, audience members, continue to think up questions and pop them in the Q&A chat, because we will get to them after our final speaker, who is Dr. Win Man Han, who is undertaking a PhD at the Kirby Institute. Win has worked as a clinical research physician at HIVNAT in Thailand, and his PhD projects investigate treatment outcomes and comorbidities among people living with HIV in the Asia-Pacific region using a regional observational cohort database, TARHOD, and long-term HIV cohort in Thailand. Welcome.
Thank you, Sarah, for the introduction. So thank you very much for the opportunity to present the work. So this is an NCD project, and then we use a cohort from Thailand to investigate the association of the non-alcoholic fatty liver disease, which is known as the NAFLD, with the diabetes development in people living with HIV. And it was presented in the CROI as a poster team discussion. Just so very briefly on the background, globally, non-alcoholic fatty liver disease on NAFLD prevalence ranges from 25 to 33% in adults, and it's often associated with the obesity, diabetes, and other metabolic complications, which are more often increased in people living with HIV. So we hypothesized that these complications of NAFLD or non-alcoholic steatosis, which is also will be increased in the people living with HIV. However, little is known regarding the risk factor and complication of NAFLD and on NASH in the people living with HIV. Therefore, we investigated the association of NAFLD plus or minus a concurrent diagnosis of NASH with new incest diabetes mellitus. So as a study design, this is a prospective cohort study, and in the cohort was based in Bangkok, Thailand, and then we defined the NAFLD as a continued control attenuation parameter more than equal to 248 decibel per minute, and NASH with the significant activity and liver fibrosis was defined as the FibroScan AST or FAST score more than equal to 0.67. And the study population will be living with HIV more than equal to 18 years old without hepatitis infections and also without the asexual alcoholic consumption. So we also excluded those with the diabetes diagnosis prior to the baseline, and then we define the baseline as the first FibroScan date. The endpoint of this primary analysis is the new onset diabetes, which was defined as the fasting blood glucose and also on the reported onset of diabetes and initiation of an anti-diabetes therapy. The second analysis was to look at the incidence of NASH with significant activity and liver fibrosis. So we presented hazard ratio using the cost proportionate regression model, and the models were adjusted for age, sex, family history of diabetes, duration of ERT, diagnosis and exposure, body mass index, hypertension, and dyslipidemia. And some of these variables are time updated variables. You can see at the bottom is the equation for how the FAST score was calculated. This has been validated in the national cohort using the liver biopsy results. So these non-invasive procedures have a very high accuracy in detecting a non-alcoholic fatty liver disease. So out of 3,000-ish participants, 1,057 participants had at least one CAP assessment. And then we excluded those with DM, no glucose measurement at baseline. We also excluded with the people with excessive alcohol hepatitis co-infection. So we ended up having 1,079 participants, and out of them, we included an analysis of 847 participants who met the eligible criteria and had at least one follow-up visit after baseline CAP measurement. So out of the 847 participants, 43% were female, and the median age at the baseline was 46 years old. 90% have the HIV RNA less than 50 copies per mil, and the median CD4s baseline was 588. Duration of ERT was 11 years. And at the baseline, 66% were on an NRTI, 20% were on PI, 9% on AST, and 6% were on TEFT. So we included a CAP measurement of median CAP measurement of 3 times over the follow-up of nearly 4 years. At the baseline, 28% and 15% have NAFLD and NASH and liver fibrosis. So 28% depth of diabetes with an incident rate of 9.1 per 1,000 per sincere follow-up. And the incident rate of diabetes with a baseline NAFLD was 0.65, compared with the incidence of diabetes without baseline NAFLD was 2.23 per 100% years, and the p-value was significant. Also, if you look at the Kaplan-Meier curve, we can see the probability of new onset diabetes was significantly higher among those with NAFLD at year 2 and at year 4 with the long-run p-value less than 0.001. And we further stratified the NAFLD status, NAFLD with NASH and NAFLD without NASH. And then you can see the people with NAFLD and NASH have a higher incidence of new onset diabetes compared to those without NAFLD at the baseline. And in the cost proportional regression model, we found that the baseline NAFLD was associated with an increased rate of incident diabetes with a hazard ratio of 2.83. And the combined NAFLD and NASH have increased risk of incident diabetes with a hazard ratio of 3.12. And as a secondary analysis, we look at the incident NASH, and then we found that diabetes and the NAFLD at baseline, obesity, duration of ART, and TAF use were associated with an increased rate of incident NASH. And this was relevant in terms of weight gain, which was related to the TAF use and other integrase inhibitor. However, we didn't find any integrase inhibitor use associated with the incident NASH in the analysis. The limitation of the study includes all the study participants are Thai or Asian ancestry, so that might limit the generalizability of findings to other population. And also a significant proportion of participants did not have CAP measurement at the cohort, so we may have included those with a higher risk of comorbidities. And again, this is the observational cohort study, so we might not include other co-founders such as genetic variants, lifestyle, or diet factors. And we also didn't have a chance to look at the cardiovascular disease rates or deaths because of low number of events in the cohorts, and has no power to analyze these associations. So in conclusions, among well-suppressed people living in HIV and Thai cohort, NAFLD alone or combined with NASH predicts the new onset diabetes, and also the diabetes with NAFLD at baseline and TAF use associated with incident NASH. These results underscore the need for the diabetes and cardiovascular risk disease management among people living with HIV and NAFLD. We believe the further mechanistic studies investigating the underlying metabolic association of these fatty liver condition with the diabetes development are warranted. And with that, I'd like to acknowledge and thanks for the study team at the HIPNet cohort, and also Dr. Angelie, Steve, and other NAS team for their incredible support in the study, and also for my supervisor at the Kirby Institute. Thank you very much.
Thanks, Wayne. So if I'll invite Rahana to join us up the top, and Gail and Joanne, if you can join online. So we're now open for Q&A. think the first question is relating to Gail's talk. I don't know if Gail is still online. Possibly. Oh, hi, Gail. I think this one was for you about is it diabetes not being listed as adverse events? Was there any signal for hyperglycemia and DM in the DTG arms? There's several reports from Africa linking dolutegravir with incident diabetes, although the data from Western studies suggest otherwise.
Yeah, it's a very important thing to look at, and you know, this analysis that we put together for CROI was very time limited because we'd only just got the final data set in. So as I said, it was a late break and we're only able to look at a few sort of key parameters. Diabetes is obviously linked, and it's important for, you know, Wynn's talk as well, because diabetes is linked to metabolic syndrome, is linked to weight gain and hypertension and a number of other sort of comorbidities that are quite important to disentangle, particularly in the context of different ART therapies, and this is very much a hot topic at the moment in sort of the therapeutic ART world. So absolutely, we will be looking at diabetes and in the context of weight gain, hypertension, and metabolic syndrome and cardiovascular risk in this 3-arm study, which will be nice to do that.
Thank you. We've got a question in the room. Can you hear?
Not really. No.
Sorry, you might have to.
Can you repeat it, Sarah?
I'm trying. It's about the HCV reinfection rate in people having group sex, and the rate was 20%, over 20%. And
so I didn't show HCV reinfection for group sex. So I had injecting drug use and chemsex. Is the chemsex that you're talking about?
Yes.
Yep, to do with the chemsex, the comment is about how there's often overlap between group and chemsex.
Oh, yeah, absolutely true. And we did look at the trajectory groups to see the overlap between the two groups, and there was a large overlap between the chemsex group, the group that were using stimulants, and also injecting drug use, but not so much with the high probability trajectory, so with the moderate sort of probability trajectory. So yeah, that's something really interesting. We did try to sort of look and see what the differences were between the trajectory groups in the populations, and we couldn't really see any clear differences. So it's quite interesting. So no indication of why people are engaging in these behaviours with the data that we have. So yeah.
I think it's also important to note that many of the patients in this study were recruited from the European cities, where there was, really high rates of reinfection, particularly in the time period of the study, related to a number of different causal factors, all of which overlapped, much more so than in Australia, where we had widespread rollout of DAs and were able to keep the reinfection rate really very low.
That sort of leads nicely into my question for Joanne. I guess it wasn't the purpose of your study, but I was interested in those kind of geographical differences that may have fallen out around risk behaviours. Are you able to comment on any geographical differences?
Yeah, so we definitely did see higher reinfection incidence in some countries compared to others. So in Australia and New Zealand, where we've got very good access to DAAs and they were rolled out relatively quickly, there was a very low reinfection incidence, whereas in some of the European countries, so Germany had a really high reinfection incidence. The UK, they had a relatively low one. And in the US and Canada, they were predominantly people who inject drugs, and it was quite high there as well.
I had a question for Wynn too. I may have missed this, but with the NAFLD and NASH being predictors of diabetes, was that independent of things like obesity?
Yes.
It was totally independent.
Thanks. So it was independent of the obesity because we included the BMI analysis as well. Yep.
And did you look at glucose tolerance testing at all?
No, we didn't have the glucose intolerance test in that cohort. So.
Okay, I think I'm getting the wrap up signal. So thanks everyone for joining us both online and in person, and to all our wonderful speakers from CROI. Have a good afternoon.